Well, welcome to another segment of Your Health Matters. Pat Williams couldn't be with us today. He had another engagement. But we have with us Dr. Pranav Periyalwar, who is a gastroenterologist who practices here in Conneaut and also in Geneva. Having Dr. Periyalwar here in our community represents a real advance for us. We haven't had a gastroenterologist dedicated to our area in a long, long time, and he has expertise in a number of different conditions that we haven't been able to really get hold of until his arrival. He practices in both Conneaut and Geneva, and he's been in town, since last
September.
September. So he tells me he's starting to get a feel for our town, for our community, and for what's going on here. And he has some topics that he'd like to talk to today, things he's been seeing, things that he thinks will really help our public to know more about.
Yeah, thank you, Dr. Bryant. I've had a good chance over the past several months to meet patients and understand some of their concerns and help to educate them about various topics in gastroenterology. I just wanted to go through some of the important things that I've discussed with many of my patients, which they weren't aware of or not fully understanding of. First of all, I just wanted to start off with colorectal cancer.
Very important topic.
March was Colorectal Cancer Awareness Month. The American College of Gastroenterology had a big push for increasing screening and awareness in that month with lots of different programs throughout the country. I think one of the most important things that people should know and patients should know is that our screening rates right now are in the 60%, and we're aiming to get close to the 80% range.
How common is colorectal cancer in America?
Its incidence is somewhere between 12 and 15% in the general population.
Whoa.
Yeah.
Whoa. Folks, that's a very, very big number.
Yeah.
Okay, that's a big number.
Yeah.
So this is an important.
It is.
This is it's important to everybody out there.
Absolutely.
Because we're all at risk.
Yeah.
We're all
I
at risk.
think it's the third leading cause of death amongst cancers out there.
And so screening becomes important.
Absolutely.
And when we talk about screening, we're talking about getting a colonoscopy. Who should get a colonoscopy?
So anyone over the age of 50, Caucasian people over the age of 50, and any African American over 45 should have their first colonoscopy, called a screening colonoscopy. After that point, then the gastroenterologist or general surgeon should recommend interval for surveillance. It can be anywhere from 1 to 3 to 5 and upwards of 10 years if you have no polyps. It's very important that you have this test. There are a lot of other tests to detect colon cancer, but they cannot treat it. They can't take out polyps. What I'm alluding to are some of the stool tests out there, like the FIT test, the fecal immunohistochemical test, which can detect bleeding as well as different assays which they can run to see whether there is any early cancers.
So if people get that kind of non-invasive test, they may be lulled into a false sense of security.
Absolutely. There are a lot of polyps and early cancers out there which are not detected. And the other thing is, if you do have a positive test, the next step is to get a colonoscopy. So I think what I've seen and what my patients a lot of them are worried about are, well, how am I going to get this procedure done? Is it going to be comfortable? Is it going to hurt? And how am I going to prep for this procedure? And I go over a lot of these things in my office.
Absolutely. So folks, nobody likes to think about a colonoscopy, but as doctor will tell you, it's absolutely painless. You don't feel it. You don't really realize what's going on. But I think it's very important to underscore, we're not just talking about diagnosis here.
Right.
See, this is a procedure where you can actually do something about it. Now, people may have heard the word polyp. They're not sure what that means. They're not sure about the relationship between that and cancer. So what is a polyp?
So a polyp is an outgrowth of tissue from within the colon. There's many different types of polyps, but essentially we break them up into benign or precancerous, and then malignant, of course. And the vast majority of people, 1 in 4 people, will have a polyp on a colonoscopy.
1 in 4
1 in 4
people. That means 1 in every 4 people
Walking around.
who is hearing this or walking around will have a polyp.
Yes, and that needs to be removed.
That needs to be removed. What happens to people if they don't remove it?
So it's a different flow which happens if you don't remove the polyp. It can take anywhere from several years. Certain polyps will stay benign. Others will become malignant and cancerous. And if that's the case, then what you have is a much more tricky situation, because they get large enough that they can't be removed by colonoscopy, and you're going to have to go to surgeries and then chemotherapies and radiation therapies and all of those things.
So, as in so many things, catching it early is really the key.
Absolutely. Early detection can prevent spread of the cancer, and it can also help your loved ones, because you may have someone, a brother or sister who's younger than you, who doesn't have cancer yet but has polyps, and they may need a colonoscopy earlier than age 50 in order to get that taken care of.
Absolutely. So, I guess one way you could look at this is that if you don't have a polyp, if you have no polyp, you can't get cancer.
Yeah, absolutely. If you have
no polyp, no cancer.
Exactly. You have a clean bill of health. If you have no polyps, you should have a clean bill of health for 10 years as far as colon cancer. You don't
But
even
if you do a colonoscopy on someone and you find a polyp and you remove it, and it was the wrong kind, basically what you have just done is prevented colon cancer for that person.
Exactly.
So you're preventing
Yes.
colon cancer.
Absolutely. Yeah, this is exactly what we're trying to do, prevent these long-term complications, and which require hospitalization, surgeries, and lots of other things which we don't want our patients to have to suffer through. And it's a relatively quick and benign test. It takes 15, 20 minutes, half an hour of your life that you're spending to get this test done. And the idea is that once we do this, then you no longer have to worry about colon cancer for at least 10 years' time.
Excellent, excellent. So 1 in 4 people has a polyp, and those polyps can be the kind that turn into cancer. We're talking about an awful lot of potential colon cancer.
Absolutely.
And the statistics really sort of bear that out. It's the number 3 killer of cancers in males and females year in, year out. And, as a culture, we tend to get maybe a disproportionate amount of colon cancer. Right. This really serves to underscore how important it is to take this seriously. Yes. Dr. Periyalwar, when you visit his office, he will explain colonoscopy in detail. He'll make sure that you understand that it really doesn't hurt, that it isn't going to be a negative experience, and the prep is nothing like what it used to be. All right, and just think of it in terms of, if you have the opportunity to prevent yourself from getting colon cancer, is that worth it?
Absolutely.
You have to acknowledge that it is. So you're really emphasizing how important it is that people be screened.
Absolutely. And I think that, if you have apprehensions, we can talk about them in my office. The prep is nothing what it used to be before. So if you've had loved ones who've had colonoscopies before, drinking big jugs of fluid, we don't do that anymore. In rare cases, we have to do that. And it's really a smaller volume amount of fluid, and it's over a shorter period of time. You're really just sacrificing about 12 to 16 hours of your life to prepare for a procedure, which is about half an hour long, and then you move on with the rest of your life after that.
Okay, so you have a patient who comes into your office, and they've been told that they need to be screened. Okay, so you go through all this, and you do the colonoscopy, and you remove a premalignant polyp. And they come back to your office, and you give them the results, and you tell them, well, this is something that could have turned into cancer, but it won't now because it's gone. So basically, you were on the way to colon cancer, and now you're not going to get it. How do they feel?
Oh, they're
Tell me that.
incredibly relieved and really happy because they understand that this is preventing their long-term health from deteriorating. And
Do they think it was worth it?
Oh, they do. Yeah, and they recommend their loved ones to get it done. I've had patients who make their spouses and their brothers and sisters, and they come into my office weeks later
Yeah.
because they're happy with the experience. And I think that they feel satisfied that they took the time to do this, and they were courageous enough to come in and get this done. And realize that it really wasn't that bad. In fact, most people have always told me that the procedure, they don't really remember what happened, and they feel like they just woke up, and sometimes they ask me, when are we going to start the procedure? I said, it's all done. Everything's done.
Everything's done.
So, we would discuss with your loved ones at the end about the result and go over things like that.
Excellent, excellent. And then, of course, Dr. Periyalwar will counsel you as to what was found, and does this mean you have to get another colonoscopy sooner, or how do you stay safe, that kind of thing. He goes over all that with you. Yeah. I do think it is important, again, to emphasize that if you've had a non-invasive test, if you've had some kind of stool screening, that does not necessarily protect you.
No, it
Okay?
doesn't.
That does not necessarily protect you. There is no substitute for colonoscopy at this point in time.
Right.
Very good. Very good. All right. Well, that's very good. I hope people heard that. I hope people will take it seriously. It's just a very, very important and very nice feeling to have, to know that you're safe. Now, one of the other things that I think that we encounter in our community fairly regularly is that people will have abdominal studies for one reason or another. They'll get an ultrasound, they'll get a CT scan for one reason or another, and they get told, boy, there's a lot of extra fat in your liver. Is that significant?
Yeah, it is. So fatty liver and fat accumulation in the liver is related to a syndrome called metabolic syndrome. Patients with this syndrome have a constellation of symptoms which include obesity, diabetes, high lipids in their blood, also called hyperlipidemia, and fatty liver. Now, what many people don't understand is that fat accumulates everywhere in the body. It also accumulates in the organs in the body, and one of the organs that it accumulates in is the liver. With time and with years of fat accumulation, you can get abnormal tests of your liver tests.
So it actually hurts the liver?
It can. It can lead to, over time, what we call cirrhosis, which is scarring of the liver.
Whoa.
And that is very serious because you require a liver transplant.
So if you can start out just with fat in the liver, which you can't feel that, right?
No.
You don't realize
No.
that's happening, right? So it doesn't give you any warning.
Right.
And just the fact that fat is there can injure the liver and injure it to the point that you might even need a liver transplant because your liver fails.
Right.
That's whoa.
The leading cause right now of liver transplant is actually fatty liver.
The leading
NASH,
cause.
yeah.
The leading cause.
Yes, more than alcohol, more than Tylenol overdoses and other types of
Hepatitis even?
Even hepatitis now, because we're treating hepatitis C so aggressively, we're having less and less. So fatty liver is coming up.
Wow. Okay. Folks, just a little context. Liver failure is horrendous. People who have severe liver problems are terribly, terribly ill. And it just destroys your quality of life. If you have the opportunity to not get to that state, it's extremely important. And even if you haven't made it to that state, if that kind of thing is going on, it just indicates that there's a process going on that's not too good for you.
Absolutely.
So if you have somebody who's referred to your office and they were told by their primary care physician that they have fatty liver, they sit down with you and what do you tell them?
So first of all, we go over a full assessment of their liver function. I go over some biochemical tests, blood tests, as well as obtain some imaging, ultrasound tests potentially, and some non-invasive ways to see how their liver is functioning. based on that assessment, we come up with a plan. I have a team of a dietitian and nutritionist, one of which works with me in Geneva, and we go over ways and strategies we can to get this under control. It can include many different things. It can include dietary modifications and pretty aggressive ones, as well as certain exercise and lifestyle changes. And primarily those are the main things, but 10% of my practice is based out of nutrition, so I do a lot of counseling for patients just to get an understanding of how what they're eating is impacting their body. And I find that in our community here in Conneaut, a lot of people don't understand what they eat and drink, even drink. For instance, carbonated beverages and beverages which are with high fructose corn syrup and artificial sweeteners can really impact the way their body functions.
This is not a very friendly situation.
No.
You've got a situation where something can be going on that can really affect your health in terms of liver function, and you can't feel it, and you don't know what's going on, and you can't see any direct connection between your diet and so on and this process.
Right.
So it takes somebody to really explain it to you.
Yeah.
And then you have to take that knowledge and really understand what it means and realize this is your chance to protect yourself.
Right.
This is your chance to defend yourself.
Yeah.
Okay, well now, so here's a person and they're working with you, and do any of these people ever need a biopsy?
On occasion, yes. There is times where we need to take a piece of the liver if we're not 100% certain whether the clinical picture fits the reason why they're having this fat in the liver. For instance, if you had somebody who is very lean, muscular, healthy, and there was an imaging test which showed that they had fat accumulation in the liver, and the liver tests were up, things may not add up fully. If they don't add up and we want to make absolutely certain, what we can do is we arrange for a biopsy of the liver. There are many different ways to do liver biopsies. I've done many myself through the skin. More and more what we're doing now is a biopsy through a vein. And the radiologists, we send them to just put a small catheter through a vein in the neck and go down to the liver and take a piece, and it's painless. And it has less complications. So I have sent patients for this, and they've had very good outcomes, and we get an idea of exactly what's happening in the liver. Sometimes we're surprised, and we say, well, there's no fat. The imaging showed there was some fat, but there's very little fat, and it's really nothing to worry about. Or some other times we're surprised in another way, and then say, well, maybe there's some other genetic condition which is causing this and predisposing someone to having early problems with their liver. But I think more and more I'm really focusing on trying to get people to understand that everything that they do in their lifestyle can impact their GI health, with their liver and with other functions in their GI tract.
You're not going to be able to really react in a rational way to protect yourself without the information.
Right.
You have to have the information. But then you have to act on it.
Exactly.
That's not always so easy to do, but if you've really got some good hard evidence and a good clear understanding of cause and effect there, it can help you.
Yeah.
It can help you. They say Rome wasn't built in a day, but you take that first step, then you take the second step, and the next thing you know, you're farther down that road toward protecting yourself and protecting your health.
Exactly.
Sometimes a liver biopsy to see how much damage has actually been done, because the liver is one of the few organs in the body that can regenerate.
It is.
Right, but you can get to a point where it's so destroyed that you're not going to be able to have decent function no matter what. Right.
Right.
And a biopsy is kind of how you tell that.
Exactly. I do want to mention, too, that we have a new cutting-edge technology available to us at University Hospital. It's called the Fibro scan, and it's what we call transient elastography, which is a long word for basically meaning it looks at how the liver tissue how elastic it is, essentially, and how much of damage and fibrous damage has been done to it.
So that's a pretty good indicator of what we call fibrosis, which
Right.
is irreversible scarring in the liver.
Exactly.
And that's pretty accurate for that?
It is. It's very accurate. So
Wow.
we're having fewer and fewer people do liver biopsies now, and doing
That's
more of
fantastic.
this. Yeah, it's just like getting an ultrasound, so you don't have to worry about feeling any pain. You just get it. They put a little probe on your belly and just put some gel on it, and it's really doesn't hurt at all.
And where is that done?
That's typically done. We do that at Conneaut Medical Center in Beechwood, and that's the closest site. But I have colleagues which perform that test in our liver transplant institute, and I can set you up and send you there directly. So you'd only have to really make one trip out there for the test, and then I could follow up with you in my office here in Conneaut.
That's great. That's a real help.
Yeah, absolutely.
That's a real help. Well, it is very common. Fatty liver is very, very common.
It is.
And if doctors telling us that it is now the number one cause of liver transplantation, this is something that, again, it's like colon cancer. It's something that's preventable, something that's modifiable, something that can just do unbelievable damage to your life and to your family, and you can do something about it.
Right.
You can protect yourself, and doctor can help you do that. That's great. That's amazing. That's amazing. That FibroScan.
Yeah, it is. It's really neat.
That's
Technology, how it's evolving.
Now, do you ever see hepatitis C out here?
I do, yeah. I have some patients which we've actually got treatment underway and we've cured their hepatitis C.
What is hepatitis C?
So hepatitis C is a viral infection which affects the liver.
Viral infection of the liver.
It is, and it's a virus that stays in your liver for years, decades. You may have had it from 30, 40 years sometimes.
Holy smokes.
And it just continually replicates and causes more and more damage to the liver. It's very important that people born between the time of 1945 and 1965 always be checked for hepatitis C. The reason being is that there was a lot more prevalence of blood transfusions back then, and there was at that time we never checked the blood that you were given for hepatitis C.
So blood transfusion is a potential way you can get it.
It is. And I have a lot of people who are veterans from different wars, and they had gotten injuries, and they were transfused blood, and they have hepatitis C, and they didn't know that until years later.
Wow.
So it's sad. It's sad because they're serving our country, and they didn't realize this is happening to them. But the good news is that we now have very, very good treatment options for hepatitis C. We have medications which cause almost no side effects, which have cure rates which are in the 90s percentile.
That's tremendous.
So, yeah.
So the key, obviously, you have to know it. You have to know you got it.
Right.
So if somebody comes in to your office and they may have symptoms, they may not.
Mm-hmm.
Do people with hepatitis C, do they have symptoms?
Not always. In fact, many don't. There is a progression when you have the virus for years, which can lead to the scarring and damage of the liver I alluded to before. At that point, some patients will have some certain symptoms, but for the majority of people who are young and otherwise healthy, they don't necessarily have symptoms.
Are there certain groups of patients who, you had mentioned
Right.
people who were born,
In that time period.
But are there other groups
Yes.
of patients that may be at an increased risk
Yes.
who should be screened?
Yes.
Who would
Anyone who's had a history of IV drug use at any time in the past, even in the 1970s and 60s, even if it's once. I have patients who have told me they've used IV drugs once and they've gotten it from a needle. Anyone who's had tattoos of any kind or been incarcerated at any time, they're at increased risk for hepatitis C. It's a non-invasive blood test which we do to detect it, and really it doesn't require. It used to, maybe even 5 to 7 years ago, we'd need to do liver biopsies to stage people before treatment, but now we use another non-invasive blood test to see how much damage has been done to the liver.
That is amazing. So wait a minute now. Anyone with tattoos?
Right.
Anyone with tattoos?
Pretty much.
Because you can get hepatitis C from tattooing
Yes,
needles.
you can get it from the needle. You can also get it from the ink, because parlors used to dip the same needle in ink for different people, and they wouldn't clean. They would clean the needle, but they wouldn't clean the ink. So there were particles of the virus which would get in the ink, and a new person would come in, and they would start doing that. They would give them a new fresh needle, but they would dip the same needle into the same ink, and you can get it from that way. Anyone who's had it non-professionally done at people's houses and incarcerated on their own, they're all at risk.
Holy smokes. You know, if you're out just walking around, you might actually see a tattoo or two,
Yeah,
you know.
exactly.
Well, folks, you know, nobody likes to think about this or think this way, but I mean, if you have a tattoo, that has been identified as a risk factor for hepatitis C, which again may not have symptoms right away, may not have symptoms for years,
Right.
may be in there busily destroying your liver without you knowing about it. Very reassuring to at least get the test and know what's going on.
Exactly.
This is something that people who are watching this program, this is where you can do a public service, because you're going to encounter people who have tattoos, members of your family, friends, and so on and so forth. You might just mention to them, hey, gosh, you know, it's in your interest to protect yourself.
Right.
You ought to get screened to see if you got hepatitis C.
Right.
Wow.
Yeah, and it's not painful. It's not anything bad you'd have to go through. It's just a simple blood test, and the treatment is all oral pills. So it's just pills now, no injections, nothing like that.
Huge advances.
It is, yeah.
Huge
And I know many of you may be apprehensive because you've heard of friends and relatives, and over the past 5, 10, 20 years who have tried to get treatment and nearly died from the treatment. But that's no longer an issue. We don't use those medications anymore. They're called interferon. We no longer use that. And we use therapies which are very safe. We monitor you carefully throughout. It's a 12-week therapy for the most part for most of my patients. And I get the medications, which is a process. Sometimes it takes up to a few months to get the medications because they're so expensive, in the order of tens of thousands of dollars. But the government and pharmaceutical companies and physicians feel it's in your best interest to get this taken care of and treated.
Oh, absolutely. Absolutely. Yeah, it's another example of a process that you can't feel.
Right.
I mean, that seems to be a common theme here. If you've got a pre-malignant polyp in your colon, you can't tell.
Yeah.
You don't know.
Right.
If you're accumulating fat in your liver, you don't know. If you have hepatitis, there's a very good chance you don't
Right.
know. All of these things can kill you and wreck your life.
Yeah.
And all of these things are things that you can do something about and protect yourself.
Right.
Wow. Okay. That's pretty amazing.
Oh, yeah, I think so too.
That is pretty amazing. Take it seriously, folks. All you have to do is see somebody who's in the end stages of one of these diseases to understand how important it is.
Right.
To understand that that's really something that you do not want to have happen to yourself or anyone you know, or anyone really.
Absolutely.
Okay. Gosh, this is really, really helpful information.
Thank you.
We really appreciate you coming on and do this.
Thank you.
Is there anything else you'd like to cover at this point?
I guess I do have a lot of patients with acid reflux. That's another common thing that I see here in the community. Acid reflux is not something that you have to live with. There are different strategies which we can discuss on ways which we can.
Now, what actually is that?
So it's when you get acid and burning pain. A lot of patients come to me and they say that they have difficulty swallowing and trouble with acid coming into their mouth and their nose when they sleep, and that a lot of pain in their stomach and sometimes right behind their chest. And that is essentially what's happening, is that acid from the stomach is coming up into your food pipe and sometimes as far as your mouth, and that's not normal. The valve which connects the food pipe to the stomach is normally closed to prevent acid from coming up. However, some people have a leaky valve at the bottom of their food pipe, and acid is allowed to come up and irritate them and cause them a lot of symptoms. In most patients who have had this for many, many years, we recommend an upper endoscopy to make sure there are no complications from the acid reflux, like ulcers and strictures, blockages in the food pipe or the stomach. Now more and more I see patients which have new symptoms of reflux and they're not able to get it under control, but there are strategies and ways which I can help to improve their lifestyle and as well as get the symptoms under control with different types of medications. And they are not lifelong medications, they're temporary, but we use them for weeks to months, and then once your symptoms are under better control, we make sure all the changes you're making to your lifestyle start kicking in and help overall.
If somebody has reflux, particularly if they've had it for a long time, does that increase their risk of esophageal cancer?
It does. What you can get is a pre-malignant condition called Barrett's esophagus. What it is the changing in the lining of the distal or the end of the esophagus, the food pipe, and the cells in there become they look more like the stomach cells. And when that happens, you have basically sometimes a mutation of certain cells which can lead to cancer. We take a close eye on these people and often have to do repeated surveillance strategies and tests, which would be upper endoscopies, to prevent them from having long-term implications of esophageal cancer, which can be very devastating.
It's a terrible diagnosis. Things in medicine are improving across the board right along, but there's still some diagnoses that are just really tough.
Right.
And an advanced esophageal cancer is a really devastating diagnosis. It's increasing, from what I understand. It's not real common, but this is important because reflux is extremely common.
It is.
And untreated, and if you've had it for a long time, it can definitely increase your risk of esophageal cancer. And getting to it early enough and seeing what's going on and what doctor can do is he can help you so that it can be arrested before it has a chance to go all that way. And if you have gotten into a situation where your risk is up, you don't have cancer, but your risk is increased, he can make sure that you're followed appropriately. Right. So that we always know that it hasn't gone that far. Right. And so we make sure that you're safe.
Yeah.
Well, it's so common. Reflux is so common that it's going to, everybody out there is going to either have had it themselves or know somebody who's had it themselves. I think it's important, as you point out, for people to understand that you don't have to live with it. No. There is something you can do about it, and doctor can help you do that. So again, it's one of those things where it might be creeping up, you don't really realize it. Yeah. Much better to know what's going on than not know what's going on.
Absolutely. Yeah.
Excellent. Well, that's an avalanche of information today, which is what we like to do. We like to give people something they can use.
Great.
I think this demonstrates how fortunate we are as a community to have Dr. Periyalwar with us.
Thank you.
We really appreciate your coming in and spending some time with us today. And folks, if you have questions about any of this, my office number is here. You can call my office, and we'll direct you in appropriate ways. You can call Dr. Periyalwar's office. If you're out there, you've heard something like this, some of the information that's been given today, and you think, gosh, I'd like to talk to him, you can call his office directly.
Absolutely, you can reach me.
You can call his office and come in and talk to him and really go over things, and he'll focus in on your specific situation to come up with a plan that's right for you. Could you could announce your number?
Yes.
But we're going to have, I'm sure during this segment, your number is going to be appearing across the screen.
Great. It's 440-415-0118. That's my main line in Geneva, and I put the Conneaut number up as well.
Well, Doctor, thank you very much for coming in.
Thanks for having
me. We really appreciate it. Okay, folks, we'll see you in a couple of weeks for our next segment of Your Health Matters.